to the IFA Global Café in Conversation with Experts. My name is Jun Wang, Special Project Officer with the IFA, and will briefly review housekeeping. We will begin this virtual cafe with opening remarks, which will be followed by a moderated question and answer session. Please do use the chat function along the bottom of your screen to indicate you have any questions or comment, and we will call upon you to post your question during the moderated discussion. If you have resources to share, please post them in the chat box as well. The virtual cafe is recorded and streamed live on the IFA's Facebook page. The video recording and resources will be made available on the IFA's website, and you will receive a follow-up email with the resources and then the next invitation. Now, it is my honor to introduce the IFA's Program Manager, Dr. Supriya Venigila. Supriya.
Thank you, June. Hello, everyone, and welcome to this week's IFA Global Cafe. As June said, my name is Supriya Venigila, Program Manager with the IFA. Today, I have the distinct pleasure to introduce to you our expert speaker for the cafe, whom I met 7 years ago during my time as a student at the University of Georgia. Joining us from Athens, Georgia is Dr. Toni Miles. As a physician and an academic, Dr. Miles brings her unique perspective on bereavement care with a specific focus on residents, families, and staff. You know, loss is one of the most painful experiences that we will ever face in our lives. Each person's grief and bereavement journey is unique, and there is a need to recognize that there is no single solution to this experience. And to acknowledge the continuing bonds after death, care providers must be equipped with the tools of compassion and understanding. This is especially relevant during this time of a global upheaval with the massive losses caused by COVID-19. As a professor of epidemiology at the University of Georgia's College of Public Health, Dr. Miles works with the advocacy group Evermore to lobby for policies that improve bereavement care in the United States. Dr. Miles's work on best practices in bereavement care make her an excellent candidate for today's conversation, and we welcome Dr. Toni Miles. Toni, the floor is now yours.
All right, thank you, Supriya, thank you. Good morning to all of you. Well, good morning from Athens, and good afternoon and good night for the rest of you who are in other parts of the globe. I am very, very happy to have this opportunity to share the work I've been doing on bereavement as a public health issue. And so what I'm going to start out doing is just going to show you just a few slides so you can get oriented. And then what I want to do is open up the floor and get your reactions and questions and thoughts. So June, why don't we start, pull up the first slide and I'll talk you through it.
Let me share this list right now.
Yeah, can you share the screen? Because I can't see them.
Yes.
Okay, so I call this project Confronting Loss and Building Resilience, because that at the end of the day, what we need to do. This is my background, and I'm sure if you want this, you can have it. Supriya did a very nice job introducing me, so we won't go through too much of that, except to say that I worked on the Affordable Care Act as a staff member during the Obama administration. I'm very proud of that history. At the very bottom, you can see my email address. You can follow me on Twitter, and I'm on LinkedIn. So, I'd love to see you out there too. Next. All right, so what I got this perspective on public health, the public health impact, the population health impact of loss because I started out talking to my friends. I will confess to being a boomer. I was born at the peak of the baby boom. So there are 10 years of cohort on either side of me. We were beginning to talk about losses in our own lives. Our parents and older family members are dying. And so that was back in 2012. And as a public health person, I began to ask, what is this doing to the overall population health? And what I started to realize, and that's why this image is up for you, loss and grief are like rain. Everybody gets wet, some more than others. And you can see that guy in the white t-shirt who has no umbrella, no coat, no nothing. He is just being drenched. When I started thinking about doing this cafe with you guys this morning, who knew that 7 years after I started this work, we would be in the middle of a global pandemic. Because you can imagine, I probably didn't get much support for doing this work. People thought, grief, that's your problem. But it's not anymore. We understand now that there are mounting losses. And we do a pretty good job of counting the bodies. What we don't get is the number of people who are connected to those deaths. And so I pulled these numbers out of the World Mortality Data Book for 2019. This is pre-COVID. These are the number of deaths by different regions. They're multiply that number you see by 1,000 and you'll have the correct volume. So overall, there are about 50 million deaths in 2019. That's pre-COVID. If there's only one person grieving their loss, that's 50 million bereaved. And we know that number is much higher. Next slide. So as any good epidemiologist, and I hope there's some in the audience, what you want is a good denominator so you can begin to ask what proportion of the overall population is having this experience. And it took a while, but I got the Retirement Research Foundation and the Centers for Medicare and Medicaid to support adding 3 questions to our state level survey. Basically, have you experienced the death of a family or close friend in the years 2018 or 2019? And when we finally got that data, and we got the data back in the fall of 2020, this is what we discovered, that almost 49% of people 45 to 54 were newly bereaved. This is new bereavement. Again, this is pre-COVID. In the state of Georgia, it's about half of the folks who are 55 to 64 years old and 44% of the folks who are 65 and over. If you take the whole sample of people who are 18 and over, who participated in this survey, you can do state estimates. There are about 8 million people in that age group. Almost half of them together are newly bereaved. I'm focusing in on the older adult population. Those proportions are higher for the younger groups. So there was a lot of bereavement before COVID hit. And what does bereavement look like? People sometimes don't know that someone is newly bereaved. And so in the survey, we also have some health behaviors that I think sort of exemplify folks who are bereaved. You would not be surprised to hear that people who are newly bereaved are much more likely to say, my mental health is not good on most days in the month. They also say the same thing about their physical health. They rate themselves as having fair or poor health. About 47% will engage in binge drinking. 53% of them smoke. And for protective physical activity, 46% of them say, no, I don't engage in any in the last 14 or more days out of a month. So these are all, I bring these to the front because if you're going to do population health work, if you're interested in actionable items, these are the behaviors that you might want to target if you're going to design an intervention to help people who are newly bereaved. Next. Yes. The other, so that's population, that's high level population, public health for those of us who are in epidemiology and wanting to do large scale population actions. I also get a lot of questions and do a lot of training for people who want to just one-on-one, what can I do as an individual? I've done work. My condolences. I just got a note from somebody that they have to go to a funeral. Anyway, what you can do, the question is, what can you do for someone who's next to you, who is bereaved? And what it boiled down to, after 60 hours of interviews with staff and people who reside in long-term care, who have lost someone, the thing you can do is say, I am thinking about you. You can offer to bring them things. You can just be a quiet presence, and you can walk them. All of these can impact all of those population metrics. So even at an individual level, you can be effective. What you should not do, and I don't know about other people's cultures, and I'd love to hear about it in the chat. In the United States, we have a lot of people who complain about not being able, they don't know what to do. They don't know what to say. And so one of the things that I asked people during the interviews that we did is I asked them, what don't you want to hear? And to a person, everyone said, they don't want to hear, I know how you feel. Even if you know exactly how they feel because you lost the same person under the same circumstances, they don't want to hear that. Grief is intensely personal, and you have to treat it as such. Some of our more religious will make the statement they are in a better place. Not a thing to say. Even if you believe that, not a thing to say to someone who's bereaved. And certainly you don't tell people they need to move on, because in the United States, that might get you an aggressive reaction. But I'm not, what I want to end this particular part of the conversation with is a video of one of the speakers talking for herself. We did 60 hours worth of it. June, I'm going to let you run that video, and I want you to, this is basically their admonition about what to do with people who are bereaved.
It's just to be kind. You know, I don't think that Mr. Rogers had it wrong. You know, number one, be kind. Number two, be kind. Number three, just be kind. And the world itself is such a scary and aggressive place sometimes. We forget that everyone has their own issues and everyone has their own weight. And if we can just stop for a second and just be kind, or show kindness, or show compassion, it can help somebody else, even if it's just for the next 2 or 3 minutes, you know?
Now, that young lady works as a music therapist in an adult residency community. And at the time we interviewed her, her husband had died of liver cancer and she was pregnant with a child. And so the first time we interviewed her, that period was about a couple of years later. And so I think she had a lot to teach us. We heard a lot of good advice. And so I'm going to open the floor up now because I want to hear what the audience is thinking. Why are you here at this, for me, this hour of the morning? What can we talk about? How can we help population health and individual health with bereavement?
Thank you, Dr. Miles, for your, for the comprehensive overview of loss and grief and addressing this collective responsibility that we have on supporting the bereaved and how best to actually do so, and emphasizing on the key message of kindness. I also want to say that bereavement can have a devastating impact on an older person's immune system. The extreme distress has been associated with an increased risk of chronic diseases, cancer, depression, anxiety, and a poorer quality of life. And bereavement has to be viewed as a public health concern and an emerging threat to population health, like you said. While we wait for the questions to be populated in the chat box, I do have some questions here for you.
Oh, wow.
Could you make...
Go ahead.
You were saying, Dr. Miles?
No, I'm just looking, they're starting to drop in.
Yes, they are. Excellent. Okay, let's call upon Ms. Frances Zenedin. Frances, do you want to pose your question to Dr. Miles, please?
Yes, good morning. Thank you very much, Dr. Miles. I was just wanting, since you started your presentation saying that bereavement is a public health issue, I just wondered, how would you translate that bereavement as a public health issue in terms of the kinds of policies that you would like to see? Thank you.
And I got to tell you guys, I did not pay her to ask that question, but that is exactly where the advocacy group that I'm working in. So thank you, Frances. First of all, policy cannot be made without measurement. So the thing I had been advocating for at least 10 years is that we just capture the number of people who are bereaved. And so my state is the first place ever to have counted the number of people who said, yes, I lost someone in the past 2 years. And I use that time frame because that is according to the longitudinal work that's been done, and I can talk about that in an academic way if you want, but that's when the trajectory of the injury starts. And so policies need to be crafted, and I'll give you some examples in a second, that respond at that moment. So whether it's recognizing that the newly bereaved person, family has lost actual resources, financial resources. There in the States, we have children who are orphaned, who oftentimes are not connected to the Social Security financing that they are due. We need a policy that makes that part of the process of loss. When a person dies, are there minor children involved? That's an analysis I'm beginning to do with the new data that I have. We don't recognize that there are people, when one person dies, the spouse may lose their health insurance. In countries where you have universal health care, that's not a problem. Here it is. And so we need a policy that says, that looks at the other people who are on the insurance that the person who just died had, and connecting those widows and widowers to healthcare, because we can show that people who are newly bereaved have a twofold risk for overnight hospital stay, for destabilization of their chronic diseases. It is in that moment. There are people who are newly bereaved who lose their housing, especially if you're in senior housing, if you're in public housing. So bereavement, while we rightly so should focus on the emotional response, the sadness, there's also structural changes that go on in people's lives. And so knowing who's connected to a person who died and how they're connected in terms of resources is one of the things I would say should drive our policy. Does that give you a place to start? Good.
Perfect. Thank you, Dr. Miles. During the course of your work, have you noticed a difference in the kind of support that is given for those who work with dying and loss, say in rural versus urban settings or high versus low to middle income areas?
Oh my goodness. So in places like Georgia, the rural bereavement issues are practically unknown. We have, in addition to having COVID everywhere, which people are now, responding to, the deaths due to opioid overdose, suicide are mounting, and particularly in rural areas. And our rural citizens, their bereavement goes unrecognized. And so what it does is, instead of the sadness that you see, what you see is anger in response to that unrecognized bereavement. And so it really is important that no matter who dies and no matter how they die, one of the things I say that because one of the things I've started to understand is that we as a society, make judgments about the cause of death. There tends to be a lot of sympathy for folks who have cancer and die in hospice. There is less sympathy for people who die of cardiovascular disease or diabetes. Interestingly enough, one of the people that we interviewed, woman in the sample, a resident of a nursing home, was angry even 3 years out after her husband died because he died of heart disease and she felt he didn't work hard enough. It is, so there has to be space in our thought process and in our responses to people who are bereaved, whether their kids die of violence or their aunts die of diabetes. So in the rural areas, you see more of that. But in the central urban areas, you see also people who die by violence, and their family's bereavement is less responded to. Oftentimes, our law enforcement, public safety officers don't appreciate that they play a role in either supporting these newly bereaved people who maybe have watched this played out in front of them, or making things worse. There's the stories I've heard over the last, I would say, 10 years have been really quite informative when it comes to framing this and thinking about what to do. There's a lot that can be done.
Yeah, how your loved one dies has an effect that can last a long, long time. You were right. There is a question here from someone who's not renamed themselves, IFA speaker. So if I can call upon you to ask your question, please. Okay.
Oh, I apologize. I'm having a bit of a camera issue, but this is actually Joni, and I did not realize that that was coming up, so I will fix that. No, I was just wondering, so your research seemed to be focused on the after effects and how to support someone after a bereavement. What, if anything, did you show that we could do on a personal or a policy level to help someone prepare and maybe better arm them to face what's coming?
That is, I mean, that's an excellent question, of course. It is kind of outside of where I've been working. So what you would get from me is speculation about what could be done. Certainly, I think older adults understand that they need to prepare their families. One of the things I learned is that we don't die, we leave a mess. And if we can minimize the amount of mess, whether it's financial, emotional, that is probably the best thing we can do for the people around us.
All right, well, thank you.
Mm-hmm.
Thank you, Joni, for your question. Jane, did you have a question or a comment, please? Would you like to pose it?
Sure, thanks very much, Supriya. And Toni, there is so many questions and conversations that you and I need to have. I guess the first thing is I feel that the world is in this space of bereavement. And I've got this image of the refrigerated trucks and the bodies being, you know, and so I'd like you to make a comment on that. But my question really is around, I don't disagree with bereavement being part of public health, but with public health systems generally, if not all, struggling to do the basics, not for marginalised, but the basics of mainstream population, then what's the business case? Because public health is based on the business cases, isn't it? So what's the business case for bereavement being part of, you know, a comprehensive public health agenda? If we're fighting for adult vaccination to be part of a business case, then how do we get our head around bereavement being part of that? So thank you.
And I swear to you again, I did not pay her to ask this question, but it is something that I've given a lot of thought to. And there are a couple of things that are really obvious to me right now. Surely you've been reading about the great resignation that's happening in the job market and employers complaining about not being able to hire people. Guess what? If we asked these people who are like leaving their jobs or not showing up to work or taking extra time off, you would find a substantial proportion of people who have recently lost someone. The advocacy group that I'm working with, Evermore, is right now moving language in the Senate to make bereavement time off a part of your job. A lot of companies will fire you if you take too much time off, or they limit the relationships that you can take leave time for. What we found is that people need the better part of a year of cycling through whatever this connection is. If it means cleaning out someone's house or just grappling with their own feelings or taking care of their losses, structural losses. It cannot be done in 3 days, which most companies will allow 3 days if it's a blood relative who lives in your house. So that's the policy. And it's not just, we may frame it as a public health problem, but if you are doing employer-sponsored healthcare, the illness related to bereavement is driving your insurance premiums. So there is a business case for making bereavement an important part of it. One of the things we're starting to look at in the, and I have another project where I've been interviewing people who work in long-term care. And some people call those nursing homes, rehab, all of that. That group has bereavement as a repetitive motion injury as part of their job. They're losing people that they care for. There are some amazing people that work in nursing home, taking care of people and doing things that a lot of us could not do on a regular basis. They love it. People love them. Those folks need employer-sponsored support. And what the employers will get in the places where I've seen it work, and I have seen it work, those employees are more likely to stay. It is a job satisfaction issue, bereavement care. So it's not, public health sector doesn't have to do this heavy lift alone. We need the employment sector to step in and do part of it as well. Does that get at your, yeah, we could have a long conversation about this.
Yeah, thank you.
Mm-hmm.
Thank you, Toni, for that very insightful response. There is a question here from Cynthia Stewart. Cynthia, would you like to pose your question, please?
Hi, Toni. It's been a long time, but thank you for bringing this to the Global Cafe. It really made me stop to think about the very intergenerational nature of loss. And I think, you know, oftentimes in a nuclear family, you lose your spouse or you lose a child. For example, a child, as I have, the sibling gets lost. The parent gets the support, the attention. And their siblings often, the sibling, depending on their age, don't have that kind of natural support group built in when they're younger. And then it made me think about, you know, Janet Sayner's pioneering work in grandparents raising grandchildren. And then with COVID, you have many people who have lost their homes, as you've said, and are living in multi-generational. And all of that is really a complicating the grief process. And it's sort of overwhelming. For how, do you see, for example, the US perhaps having, as UK does, I don't know if it's commissioner on loneliness, somebody who really takes this mantle?
Oh, I don't know if the US is that evolved. And I hate to say that. I am a US citizen all my life. I'm from Kansas. I get that. We are reluctant to talk about loss at all, right? One of my other favorite phrases, you'll find that I have a lot of little favorite phrases as I talk to people at different educational and receptive levels. Denial is not just a river in Egypt. Okay, so we've got to, one of the other things that Evermore is lobbying for is a White House Office of Bereavement, because we are in a very, very tenuous time when it comes to bereavement. You've got a heady mix of people who are newly bereaved. They're sad, they're angry. It is complicated by the growing number of people with dementing illness. I mean, I wrote the demography section for the state of Georgia. I know back in 2010, there were about 250,000 people with mild to moderate cognitive impairment. We are in a longevity society, and Alzheimer's and other related dementias are an issue. And all of those create a mix of things. They're not insoluble, but if you don't see them and you don't measure them, you can't fix them. So Cynthia, you're definitely starting to see the outer edges of what is a complicated, yes.
Thank you, Dr. Miles. There is a comment here from Ms. Frances Wilkinson. Frances, would you like to please speak about the issue you brought up?
Sure. I just mentioned that in Canada. Can you hear me?
Yes, yes.
Oh, okay. We have assisted dying in Canada now. So people who are very ill and wish to have a medically assisted death can do that. And I work with a group called Dying with Dignity. So I'm pretty involved with people who are seeking this. And, you know, it's obviously, well, we think it's a good thing, but we certainly have found that for families, that often complicates, I think, their grief and bereavement, because they're often of very mixed views about this, about whether they're supportive or not. And then coming to terms with it afterwards, I think, is a problem. We're starting to look harder at how families, what sort of supports they need, because this really is a new issue, I think, in the whole bereavement area. But it's, as you were talking about other, you know, the circumstances of different circumstances where people die, this is yet another one that introduces a lot of complicated thoughts from people that are bereaved.
Yeah. Now, let me just piggyback on that. There are three, as near as I can tell, there are three researchers on the planet that think about loss in a population level way. One of them is in Toronto at the university, and has gone to India to look at 1 million deaths. Because apparently, if someone dies at home, you know, the family is left to grapple with what they do with the body and the circumstances and all that other stuff, as long as it's not been, you know, by nefarious means. So that's one approach we could learn something from, I think, that would add to what you just asked. The other group is in Sweden at the Center for Health Equity Studies. They've looked at their registry and looked at the long-term health effects, again, for different causes. And there is a definite subset of people who will have psychiatric issues. What the folks in Sweden can't give you is the granular detail that the folks in India can give you. And I like to think that my research is somewhere in between, so I can give you the hospitalizations and the psychiatric stuff. It is, you would not be surprised to hear me say, as a researcher and epidemiologist, we need more data so we can do cost effective. I know Jane is always really, it's really important that we understand we can't do everything, but we can do better than we're doing now.
Definitely. Thank you, Dr. Miles. There is a question here from Jane Pedersen. Jane, would you like to please pose your question?
Sure. This is Jane. I provide primary care services to individuals living in long-term care. And what got me thinking about this is I was taking care of a woman who has mild cognitive impairment. And she made the comment, she said, you know, I still miss my mother. And, you know, she's 80 some years old. And she said, because she's the person I always used to be able to call with questions. But when I tell people this, they want to put me on a medication. And so we had a conversation, and I went to go and do my charting. And I thought, well, how do I chart this conversation? And when I looked in the ICD codes, you know, prolonged grief reaction seemed to be the only thing that was anywhere close that I could put this, you know, kind of figure out how to fit this within the structure that we use. And it really got me thinking about how, you know, how does this, or how does how we are asked to chart, bill, etc. Is this having an effect on how we address grief in the healthcare system? Does this somehow make it more of a medical thing that does need to have a medication versus I think she really just wanted to talk about that she has times where she still misses her mother.
I couldn't pay you guys to come up with the questions that you're coming up with. This is great. So I have two reactions to the story that you just told. And I love Jackie's grandchild. Is that a grandkid? Yes, perfect. What I've learned from all the conversations that I've had with people is you never completely forget the person that you've lost, that you're connected to. That's not complicated bereavement. That is coming to terms with that person. One way I describe that is grief lays mineral deposits we later mine. And so, personally speaking, my brother died a while back, and he is very into beauty and makeup and all that other stuff, which I wasn't. And so he gave me some tips to keep my dewy, fresh complexion. And so when I do those, I think about him and it makes me smile. So your patient's expression of missing her mom is completely appropriate. It's how we consolidate, how we pull back the energy that we've invested in another life. Now, there is a thing that's complicated bereavement, and that is folks whose ability to live their lives are disrupted by the loss for an extended period of time. I didn't believe it. I must admit, I was a doubter, but there are people out there who will need psychiatric intervention of some kind. But how we sort them, we don't know yet because we haven't given it, we don't have a good denominator. People who work with complicated bereavement don't know what normal long-term grief work looks like. And so you can't sort those two cases. So does that, Jane? I mean, yes. Does that get at your? Okay.
Yeah, it does. It was just something I'd kind of been pondering. And as we were talking here, it's just like, are we helping ourselves? Are we pushing us to do things for some patients that maybe isn't really what they want and or need? And where other options or just listening may be the best intervention.
Yeah, I'm all for put your ears on.
Definitely. We have time for two more questions. And so for now, I'll call upon Tracy Carroll, please. Tracy, would you like to pose your question?
Yes, and actually I did have two questions, but my first question is about the loan process and system in the United States. We have a system that is discriminatory toward people who have lost a loved one. Let me just give an example. I have a dear friend whose husband passed away while they were in the process of selling their home and buying a condo. The lender rescinded the loan for the condo they were purchasing, despite the fact that the spouse would have plenty of money to buy the condo after the sale of the home. And this happened within maybe a week and a half of the whole process of selling their home and buying the condo. So essentially, she found herself being homeless. She and her children had nowhere to go. In the interim, they were able to stay with neighbors for a while and then finally found an apartment. But the whole loan system is so distorted in that they identified her as someone who didn't have enough income to purchase a condo, though she would have an extraordinary amount of money to buy the condo when her house closed. So how do we fill this gap in process and in our business community where it comes to loans and those who have recently passed away? Because not only was it a terrible situation with regard to not having a home, she was going through some of the most stressful times in her life. Number one, selling a home. Number two, buying a home. Number three, mourning the death of her husband and having to go through all these moves in the process. And also on top of that, we were flooded here in New Jersey, and the things she had in her storage unit was flooded out. That was on top of it. So this is just a whole conglomeration of stress that this poor woman has faced. How do we fix it from a process perspective in the loan industry? And how do we then support her through this process in more of a social services way?
Wow. All I can think of is a 4-letter word, which I shouldn't utter in an international setting. And I'm not trying to make a joke of this, but there have been times during the pandemic, if you wrote this as a storyline, Hollywood would say it's not, this is not legitimate, this is too much. So number one, my heart goes out to this lady who has endured so much. I think the loan part of it, if there are any lawyers on the call, reach out to this person, especially if you're in New Jersey, because this loan company needs to have their hands slapped for doing that. Women, some of you young women are too young to remember when women couldn't get their own credit. I mean, it was a thing. And this sounds like one of those. But more to the point, this woman is going through a stressful period that can show up as a heart attack, destabilized diabetes, a fall, and the person who's providing her health care will not see those events in this larger context. So it is, and being homeless, oh my God, I don't know what to say, really. I do like that you brought this up, because I do talk to enough people and I will find wisdom in the room somewhere. Anybody want to comment on what she said?
Not entirely sure.
We have
I'm sure. Okay. Oh yeah, Dr. Barrett.
Well, Supriya and Toni and people on the call, I mean, we're living in a very compartmentalized world. And I think that, the video clip that you had, kindness, 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 I would add grace to that one. Grace and kindness go a long way. Because I think also we tend to throw stones at the wrong people. They are doing their job. They are doing their job within their framework of their purview. So, how can we actually be drivers of systemic change? And I think that's what we've heard today. How do we unpack the systems and try and sort of chisel into it? So, we're all frail. We're all human. So I understand, I concur with your comments and,
Yeah. So we don't have an answer for you, but we appreciate hearing the story. Supriya, you want to?
Yes. There is, one last comment from Bridget Sam Bailey. Bridget, would you just like to speak about what you just typed? Okay, I'm not sure if Bridget's still with us, but what she said was she has brought up her only child to be prepared for such a loss. And she told him that she has to keep focused and on what she was
sorry,
like.
I didn't realize I was muted. Yes,
okay, yes, please go on.
For the greater part on my own. And I've sort of talked about going away about my dying, and that he mustn't be afraid when that happens. He must keep his head on and don't grieve for me until he's seen me off. Now he's 45. He's accepted what I told him. He's taking very good care of me because my husband passed away several years ago, and it's been just the two of us, and he is my life. He has a life of his own, but he still takes care of his mother. That's what I wanted to say. And I'm in the middle of that picture there, but I can't show myself. My hair isn't tidy, and I've got no makeup on. I won't be going home like this.
Yeah. Thank you for that. That's great.
You know, Bridget's made a very important point about preparing someone. And, you know, that's also something that we need to think about and work towards when we think of bereavement care programs, for instance. You know, and as we come to the close of this cafe, I'm going to make a few closing remarks, and then we will come back to you, Dr. Miles, for final comments. And first, I would like to thank you for taking the time to speak with me in the very beginning at the bus stop, and then joining us today, many moons later, to answer our questions and making this a deeply insightful and thought-provoking session for us all. And I would like to thank the IFA staff, Ms. Jun Wong, Special Projects Officer, and Ms. Ashley Patrick, our Media Marketing Communications Officer, for their invaluable assistance in the smooth running of this town hall. And as you can see on your screen, next week, we have the honor of hosting two speakers, Dr. Marsha Ori and Dr. Matthew Lee Smith from the Center for Population Health and Aging at Texas A&M University, who will speak to us about building the case for resilience in the UN Decade of Healthy Aging. And, you know, just to segue onto the next, the decade is a central component of the upcoming IFA 15th Global Conference on Aging that will take place 9th to 12th November 2021, both in person and virtually in Niagara Falls, Canada, where we will have discussions with experts and thought leaders in advocacy, brain health, vaccination, retinal diseases, aging, and registration is open, and I encourage everyone to attend either virtually or in person. And Toni, I now hand the floor over to you for takeaway messages, please.
Thank you. I'm always appreciative of having an opportunity to get these crazy ideas out there. They were long in the development. I didn't tell you guys, but I started my career as a physician during the AIDS epidemic in the 80s. And, you know, every day we saw young men die who were the same age I was. And I saw all the complicated, as a medical resident, I saw all the complicated reactions that family members and friends would have. And I felt like I was pretty much abandoned by the people who were supposed to be training me to be a doctor. And so it's taken years to evolve to this thought process. But I think it's, you know, it's where I am right now. So I just want all of you to go out and do something to make the world a kinder place, and be patient with people who are bereaved, because everybody, COVID, when we finally do the retrospective on COVID, which we cannot do yet. I mean, I live in Athens, Georgia. We are having a major spreading event this weekend. Yes, football. 92,000 people will be packed in that stadium, not a mask in sight. Some of those people are bereaved and they don't care about themselves. I am convinced that is what is part of what's going on. So have pity on them and stay out of the hospital. I shouldn't say that. Anyway, thank you all. Hope the rest of your day goes well. And, you know, drop me a note. I'm open for conversation. Thank you, Supriya. And thank you, Jane, and thank you, June.
Thank you so much, Dr. Miles. And thank you to everyone for being a part of this very important conversation today. And we will see you again next week for another very special Global Cafe, same time, same place. And I wish you all a very good rest of your day. Thank you.